Haemolytic disease of the newborn and rhesus status in general is a very important consideration during a pregnancy. However, it can be a little bit confusing to understand exactly what it means and why it matters. So here I've got a diagram which very simply illustrates the separation between the fetal circulation and the maternal circulation. So normally these should be kept separate because there is an interface that exists in the placenta. However, there are a number of reasons, which I'll come on to a bit later on, that can lead to fetal blood basically leaking into the maternal circulation. So this only applies to cases where the baby is positive for the Rhesus D antigen and the mother is negative. So imagine there's some sort of breach that leads to some of these fetal red cells getting into the maternal circulation. So given that the mother doesn't normally have D antigens on their red cells, it's recognized as foreign. And IgM antibodies are generated against these antigens in the first instance. So the main thing to remember is that IgM antibodies, which are generated in the acute phase of an infection or any sort of exposure to foreign substances, are unable to cross the placenta. So in this case, in this initial pregnancy, it doesn't really cause any problems. So it lies the red cells that leak into the maternal circulation from the fetal circulation, but it doesn't actually affect the fetus itself because it can't get through that barrier. Problems start to arise in future pregnancies where the mother's immune system would have matured the response and plasma cells will produce IgG antibodies against the D antigen, which are able to cross the placenta and cause lysis of the fetal red cells. So this is why fetuses can become profoundly anemic and they start generating red cells elsewhere in their body, leading to hydrops fetalis, where they develop enlargement of the liver. And given that the liver is so preoccupied with making red cells, it doesn't make enough protein, and hence they become very edematous and fluid overloaded. So it's all a cascade of events that starts off with exposure of a rhesus negative mother to rhesus positive blood from the fetus. And the key point to remember is that the antibody response is initially IgM and is unable to cross the placenta. However, in a future pregnancy, that response would have matured to produce IgG antibodies, which can then cross the placenta and affect the fetal red cells. So what can we actually do to prevent rhesus negative mothers from being exposed to this rhesus positive blood? So a sensitizing event is a term used to describe anything that really causes a breach in that barrier between the maternal and fetal circulations and hence leads to exposure of the mother to fetal red cells. So examples include any termination of pregnancy, ectopics, miscarriages over 12 weeks and various other things that can cause some disruption of that interface. The way that you manage it does depend on the trimester in which it happens. So in the first trimester, the fetus will have relatively little blood volume, and hence it's relatively unlikely that a substantial amount of red cells has actually leaked into the maternal circulation. So it is low risk, and you give 250 units of anti-D immunoglobulin. The idea is that it coats the red cells that have leaked into the maternal circulation such that it essentially ushers it away like a bouncer in a nightclub basically, and prevents those red cells from being detected by the maternal immune system and mounting a response. In the second trimester, 250 units should be given within 72 hours of the onset of whatever sensitizing event, and something called a Kleihauer test should be done as well. This is a test that quite cleverly makes use of the fact that fetal and maternal blood has slightly different properties, and hence you can do this chemical test, which basically allows you to quantify how much fetal blood has leaked into the maternal circulation. So that can be used to determine whether any additional anti-D immunoglobulin needs to be given on top of the 250 units. In the third trimester, because the baby has considerably more blood than they did earlier on, 500 units should be given in the first 72 hours and a Kleihauer test again should be performed.